All right. Hello, everyone. Welcome to the ASCO Direct Total Health ASCO updates. This is the panel discussion for the Hematologic Malignancies abstracts from ASCO 2021. Today we have myself. My name is Tapan Kadia. I'm currently faculty in the Department of Leukemia at MD Anderson Cancer Center in Houston. And we are fortunate enough to have today Dr. Jake Soumerai from the Massachusetts General Hospital in Boston, Massachusetts. You guys have all just finished viewing the leukemia and lymphoma abstract session. And so we're happy to take any questions. I think Dr. Soumerai is going to kick it off with some questions that we've already have in the chat box. Jake?
Great. Well, thank you so much for having me here today. We've got some terrific questions that have come in. So the first, is there any difference in response in 17p deleted or p53 mutated patients who are put on either Abrutinib versus Acalabrutinib? It's a great question. I would say we do not know if there are any differences in activity between BTK inhibitor agents in 17p deleted patients at this point. I'd say that there is more long-term data with Abrutinib in patients with p53 aberrancy, but there's, in my opinion, no sort of biological rationale why you might prefer one agent or the other. So I do not use 17p as a reason to select a BTK inhibitor.
All right, thanks, Jake. So I think I just got a question here on the blinatumomab ponatinib study in Philadelphia positive ALL. This was a pilot study again, in line with the recently published study of blinatumomab and dasatinib in Philadelphia positive ALL that was in the New England Journal of Medicine. Small pilot study from MD Anderson where they combined ponatinib and blina in first line and relapsed refractory ALL. And so the question is, how do you manage CNS prophylaxis when using blina ponatinib? And that's a great question, right? So typically when treating Philadelphia positive ALL, we're using intensive chemotherapy, often hyper-CVAD based. So you not only get the high-dose cytarabine based systemic chemotherapy, but also frequent intrathecals throughout the treatment. And so with blinatumomab, which is sort of a chemotherapy-free regimen, we've been using, we still give intensive intrathecal therapy. We give up to 12 intrathecals per course. So two intrathecals per cycle. And for the entire course, we try to make sure we have 12 intrathecals for prophylaxis CNS therapy in patients who have active CNS disease at the time of diagnosis. We do twice weekly LPs until they clear, then 4 weekly LPs, and then every other week for 6 more weeks. So we still have significant CNS prophylaxis with chemotherapy. I suppose that's the only chemotherapy portion of that regimen, but that's how we manage CNS prophylaxis with blina and ponatinib.
Got another terrific question here. Are there any patients for whom you would be more inclined to recommend Abrutinib over Acalabrutinib in CLL? It's a great question. I would say that for one, I think it bears mentioning that there is not a right answer, that we have no overall survival difference between the agents. And so although we now have randomized data that demonstrates a safer, a favorable safety profile with Acalabrutinib, this has not to date translated to a survival benefit. So both are completely reasonable, appropriate, although I typically do use Acalabrutinib at this point based on these data. However, CNS disease, which occurs rarely, but does occasionally occur in patients with CLL, we certainly have more established experience with Abrutinib in terms of crossing the blood-brain barrier than we do with the second-generation BTK inhibitor. So this is one scenario where I have used Abrutinib preferentially.
All right, thanks, Jake. I think I have a very similar question. I think we both covered the non-inferiority study of Acalabrutinib versus Abrutinib. I think that's clearly a high-impact study, and I think will clearly make a difference fairly early on in management of patients. And so the question is, are you putting newly diagnosed patients now mostly on Acalabrutinib or Abrutinib? And that's directed to me. And then I think that indeed, based on this data, based on our own experience, even prior to this study resulting, I have shifted and leaned towards putting most of my newly diagnosed CLL patients, if I'm going to use a BTK inhibitor, I tend to prefer Acalabrutinib. And Jake, I'm curious, how about you? What are your thoughts on that?
Yeah, I feel the same way. I mean, from my perspective, it's clearly non-inferior, and given the safety profile, I don't see downside in that decision. And so I've preferred to use Acalabrutinib if I'm using BTK inhibitor monotherapy.
Okay, great. And then, okay, I think, go ahead. You want to go ahead?
I'm sure. So there's another, so there's another question here. Do you use ibrutinib venetoclax off study based on these data and other published data, including data from Dr. Kadia's institution on this combination? I think these are really exciting data. And I think that, I obviously await the randomized data to help, but today in newly diagnosed patients, I'm not using IV. In patients who require initial therapy off study today, I'm using either venetoclax with inotuzumab or a BTK inhibitor as a single agent. And Dr. Kadia, I'm curious if you have any thoughts on that as well.
Yeah, no, I agree with you, Jake. I think that even though we're doing the study's open. I think that we do not treat these patients off protocol with ibrutinib venetoclax. And as you said, the data is fantastic. High response rates, high clearance of MRD, or at least low clearance. In some patients, we're able to stop therapy. Certainly very durable responses over years, even in the recent follow-up. So very exciting, very active, but we're still doing that in the setting of a clinical trial. I think off protocol in patients who are not, we're using BTK inhibitors or Ven CD20 upfront. And there was another question sort of on the same line. So I think this is a really popular study, and I think rightfully so for oncologists who are watching this. If there is a patient who is on ibrutinib currently, do I switch them to Acalabrutinib based on the current data? Interesting question, and actually this has come up quite a bit. In general, if the person is on ibrutinib and doing well, and what I've done over the years is, people who are on 420, I may drop to 280 or 140 based on side effects and tolerability, especially if they're having a good response, and they tend to do okay. So the most part, with dose reductions, if patients are doing well on ibrutinib, I leave them alone. But if there's any issues with toxicity, whether it be AFib, whether it be diarrhea, pneumonitis, or fatigue or something, I do actually go ahead and switch based on that. Similar to how I would have done, let's say in CML with TKIs, if a person is on one, has a decent response or not having a response, but is intolerable, I often switch to an alternative TKI. So it's nice that we have that option. Dr. Soumerai, is that your practice, do you think? Or?
Yeah, I do the same. I have a hard time running away from a winning horse. So if somebody's doing well on ibrutinib, I do not jump ship. It is a great question coming in. So sort of switching gears to Hodgkin. How do you treat a patient with bulky early stage classical Hodgkin lymphoma? Hodgkin lymphoma is a disease with a ton of data, and there are oftentimes multiple right choices for patients with previously untreated disease. So, I have historically, and I would say that I will continue to treat these patients with bulky early stage disease using the Rathel approach. About a third of patients who are treated on the Rathel study, which randomized patients who were PET negative after 2 cycles of ABVD to either an additional 4 of ABVD or 4 of AVD without the bleomycin, with the goal of reducing the pulmonary toxicity, demonstrated that these were equivalent, associated with equivalent outcomes. And so because a third of those patients had bulky disease and there was no difference in outcomes based on bulk in that study, this has been my approach for some time. And so for patients who have bulky early stage Hodgkin, I anticipate continuing to approach them as I have.
All right, great. There was another question that came up. Again, I'm going to go through it quickly because it's the answer I think is the same, about a young CLL patient with mutated IGVH who didn't want FCR, went to ibrutinib. was on ibrutinib for 12 months, doing really well, no AEs and CR. Would you switch? That particular patient, I may not switch, actually. I probably would continue. If there's any issues with AEs, sometimes I try dose reduction, particularly in the hypertension. I think I've noticed that people who get really uncontrolled blood pressure, just dropping to 280 or even 140 in some cases actually mitigates that blood pressure issue. And so I'll do a question that came in for the MDS abstract. So there was a nice abstract, again, it was a poster, but I thought it could be potentially practice changing in the future. So I think it was an early glimpse of what could be in myelodysplastic syndrome. As you know, we've been using HMAs as the standard of care, either 5-azacitidine or decitabine for years now, with reasonable response rates, improvement in overall survival, but we need to sort of move the needle. And I think one opportunity is in patients with MDS who have IDH1 or IDH2 mutations. This particular abstract looked at IDH2 mutated MDS and the use of enasidenib, the IDH2 inhibitor. It's very well tolerated, right? And so the idea is, can you give this to patients and improve response rates and outcomes? And so the abstract looked at patients receiving either AZA plus IDH2 in the front line, or patients who have failed hypomethylating agents. Can you just give them IDH2 inhibitors? And the question is, in an IDH mutated MDS patient, would you consider moving from AZA IDH2 on the trial and then going into single agent IDH2 inhibitor after a few cycles if you encounter cytopenias? I think that's an excellent question, and actually, and sort of right on the money, right? So in many of these patients, they get 1, 2, 4, 5 cycles of azacitidine plus IDH inhibitor. And in any MDS patient, you often see some cytopenias or some slow count recovery. And so many of these patients on the trial who are on the combination, who are seeing some cytopenias or delayed count recovery, and they still have the IDH2 mutation, we frequently will drop the AZA and continue on with the single agent IDH2 inhibitor, sort of a maintenance long-term. And I've seen some nice durable responses with excellent tolerability. So that's a great question.
There's a couple of additional CLL questions coming in, actually related to concurrent medications, which I think these are great topics. Why is acalabrutinib contraindicated with a PPI? So it affects absorption, and so you do not want to use a proton pump inhibitor in patients who are receiving acalabrutinib. You can use an H2 blocker. You have to time it appropriately. And speak with your pharmacist. It's just a reminder that all of these drugs have a whole slew of drug-drug interactions that are really important to be mindful of. This is one reason why there is some interest in the other second generation BTK inhibitors, zanubrutinib, which can be given with PPIs. And so this is currently not FDA approved for CLL. It's FDA approved for mantle cell lymphoma. But these are the issues that honestly affect oftentimes selection of agents, is because the last thing you want to do is make somebody's CLL better, improve their fatigue and adenopathy, but have them concerned about worsening GERD. So I think that's a great question. The other question is, maybe just to couple those together, I'm seeing a great deal of shingles in elderly patients started on BTK inhibitors and CLL, to the point that I'm seriously considering starting all patients on acyclovir prophylaxis with starting these agents. Are you seeing this in your practice? We do see shingles. I mean, I'll be curious to hear Dr. Kadia's response as well. I do not see this disproportionate to what I've seen otherwise in patients with CLL. Currently, the recommendation is not to incorporate sort of across the board outside of somebody who's already at higher risk VZV prophylaxis. Although I will say that for patients who have had frequent outbreaks, that there are patients for whom I do consider this, and I do try to ensure that folks get the new zoster vaccination as soon as it's available to them. And we have data actually demonstrating it was published in Blood just this last year, that's highly effective in patients with CLL, including in patients receiving BTK inhibitors. So if you have somebody on a BTK inhibitor and you're concerned about this, I would encourage vaccination in those patients.
Yeah, Dr. Soumerai, I agree with you. I think that we certainly recommend the Shingrix, the vaccination. But what we are doing, and this is probably maybe different from most institutions, is that we almost universally put these patients on Valtrex, valacyclovir, as prophylaxis. And so we've seen very few shingles outbreaks. It would be rare to see that in our population. Again, a lot of our patients are going on studies, so ibrutinib ven or something. So there's a higher reason or more compelling reason to start the Valtrex. But even in patients with BTK, we go ahead and start them in CLL. So that's how we're doing it. So that's saying, I'm going to answer one of the CLL questions since we're still on that topic, and then move to the ASA. How old is the youngest patient that has been treated with CLL? I don't know the answer to that. I can tell you just about 3 months ago, I met a young lady, 28 years old, who had just delivered a healthy child. And right after delivery, probably 2 weeks after, she was found to have a significantly elevated white cell count, diffuse, rapidly progressing lymphadenopathy, which was initially thought to be some sort of Burkitt's or Richter's type transformation, and turned out to be just a high-grade CLL. And she was 28 years old. I'm not sure, Dr. Soumerai, what your youngest age has been lately. I can't remember any other ones.
Yeah, we've had a few in the, I think I've had one patient in the late 20s, similar, and a number of patients in the 30s. I think it's obviously a fairly rare event, but it certainly occurs.
Great. And so the question on the HMA study was, can you use AZA 3 days instead of 7 days? Absolutely. We've used that frequently for severe cytopenias, where we dropped the AZA from 7 days to 3 days. There was a randomized trial done in MDS. Dr. Garcia-Minero from our institution is the last author, looking at 3 days of decitabine versus 3 days of AZA in low-risk MDS, and certainly both were equivalent. There is a third arm comparing it also to AZA 7 days, and that part of the study hasn't been published, but what we found is certainly in low-risk MDS, the 3-day HMA-based therapy is as good and much safer in terms of myelosuppression. So you can definitely use that.
And the switching gears a little bit, there's a great Hodgkin question. So what is preferred for PET positive patients? Escalated BACOP or high-dose transplant and autologous stem cell rescue? I'd actually add a third option there, which is ABVD. And it really depends, right? So a patient, and it depends on the scenario, it depends on the stage of disease. I think that this is, but if you have a patient who is PET positive, remember that these by and large, these patients have not been randomized to different strategies. And so we don't have high quality randomized data that tells us that we should be escalating all of these patients to be a COP across the board. So in patients with just a little bit of blush, a Deauville 4, that is clearly a terrific response. These are patients where I have often continued with ABVD, and the number of cycles and additional considerations, whether you incorporate radiation, et cetera, depends on the stage, risk, et cetera. High-dose transplant autologous stem cell rescue is really something I reserve for patients who really clinically have refractory disease. And those are patients where I biopsy first, make sure it's definitively Hodgkin, because sometimes we can see collision lymphomas with gray zone or large cell or something else there in the node. And so you want to make sure you're treating the right histology. And then those are patients for whom you consider moving straight on to second-line chemotherapy.
So can I ask you a question, Dr. Soumerai, just on that topic? How do you incorporate brentuximab in a patient like this, who has sort of refractory Hodgkin's, high grade? Where do you fit that in?
I think it's a great question, actually that is I had a patient just a few weeks ago where this came up, who progressed on their interim scan. Biopsy confirmed that this was the same classical Hodgkin lymphoma, and this is a patient for whom a non-cytotoxic chemotherapy approach is compelling, and so we do have recent data on BV-Nivo. in this population with, frankly, excellent response rates, high CR rates. And so this is a regimen that I've used for patients with primary refractory disease. Although, of course, we don't have randomized data that tells us that this is preferred to ICE. But this is something that I've been doing for patients with early primary refractory Hodgkin.
Great. There's a question which I think I also would like to hear Dr. Soumerai's opinion. What are some options for the treatment of recalcitrant chylothorax and CLL? You know, I've seen a bunch of these lately, probably in the last year, at least 2 or 3, where you have this kind of, you know, unexplained persistent pleural effusion chylothorax. Many times they're not chylous necessarily. Sometimes they're just simple effusions, but there's no obvious bulky adenopathy or anything. The way I would, so we drained it, we tried pleural catheters, pleural drainage, pleurodesis. But I think treatment, adequate treatment eventually, things like BTK inhibitors or BTK, BCL2, CD20 monoclonal antibodies, we've tried to sort of adequately and optimally treat the disease and have seen some responses. But I agree, it's a difficult problem. I don't know if Dr. Soumerai has other experience in that.
Yeah, I feel I've had the same experience, and the and that ultimately optimal CLL treatment has really been necessary, and whether to select one option over another, I think, is really sort of anecdotally driven. But I've used the approach I would otherwise have used in those patients, be it a BTK inhibitor, venetoclax-based regimen, or otherwise. But these can be really problematic cases. So thank you so much for your time. We now have a quick break. Make sure you have selected the non-CME presentation you would like to watch by going to the All Session tab and adding it to your schedule. These are both really great learning opportunities, and you will receive a gift card for attending. Terrific. Enjoy your quick break. Thank you.
Thank you, everyone.